Good afternoon to Dr. Mahathir and my fellow friends who are watching this presentations video. I'm Nicholas. Today I will be presenting my topic on the transfusion science and blood banking regarding hemolytic disease of the newborn, or HDN. Now, HDFN or hemolytic disease of fetus or newborn is an alloimmune hemolytic illness of the fetus and newborn induced by the binding of the maternal immunoglobulin or the G antibodies to paternally inherited antigens present on the fetal, but not maternal red blood cells. Antigen-negative women may either have naturally occurring antibodies to certain RBC antigens like anti-A or anti-B, or develop antibodies as a result of previous blood transfusion or silent fetal-maternal hemorrhage during pregnancy or birth. Now, maternal immunoglobulin G antibodies bind to fetal RBCs, causing hemolysis or erythropoiesis inhibition. As a result, anemia in the fetus or neonate, extramedullary hematopoiesis, and neonatal hyperbilirubinemia may occur, with severe cases culminating in fetal loss or neonatal death owing to hydrops fetalis. Now, autoimmune HDN is classified into 3 subtypes based on the antigens involved: rhesus, minor red cell antigens, and ABO. Now, alloimmunization of the mother to blood type antigens occurs as a result of exposure to non-self antigens on RBCs during transfusion or preceding pregnancy. RBC alloantibodies may be harmful during transfusion or pregnancy, depending on their specificity and the presence or absence of cognate antigens or transfused or fetal RBCs. Figure 1 shows the diagram of hemolytic disease of the newborn. As we can see, maternal circulations here happens, and maternal rhesus negative red blood cells and fetal rhesus positive red blood cells in the maternal circulations, and therefore it will cause anti-rhesus antibody presence, and the maternal anti-rhesus antibodies access to the platelets and agglutinations of the fetal rhesus positive red blood cells occurs with the anti-rhesus antibodies. Now, etiology. Possible causes of pathological jaundice should be considered, including intrauterine congenital infections, such as erythrocyte membrane defects, hereditary spherocytosis or hereditary elliptocytosis, even hereditary pyropoikilocytosis, and RBC enzyme deficiencies such as glucose G6PD, includes hemorrhages, hypothyroidism, GI obstruction, and metabolic diseases. Rhesus system antibodies and ABO system antibodies are 2 common causes of hemolytic illness in newborns. ABO HDN affects nearly mainly the babies of women of blood group O. Now, the majority of severe instances of HDN have been ascribed as rhesus D incompatibility between rhesus D negative woman and her rhesus D positive fetus following rhesus D alloimmunization during a prior pregnancy. Figure 2 shows the sensitization occurs during the first pregnancy. If we see the first pregnancy here and the second pregnancy over here. Now, pathogenesis. Maternal alloimmunization might be induced by previous incompatible blood transfusion or by previous or current fetal maternal hemorrhage. Only antibodies of the IgG class traverse the placenta actively. To compensate for the anemia, the fetus circulation becomes hyperdynamic, resulting in cardiomegaly, eventually fetal hydrops, a disease characterized by edema in fetal skin and serious cavities. This disorder is defined by bilirubin accumulation in the basal ganglia and brainstem nuclei, and is associated with long-term morbidity, which may include a severe type of ethioid cerebral palsy, hearing issues, and psychomotor impairments. Now, the figure 3 here shows diagram of the pathogenesis and clinical findings of HDN. Signs and symptoms. The most frequently encountered symptoms of HDN are pale complexion, amniotic fluid, umbilical cord, skin, and eyes became yellowish, excessive liver or spleen size, excessive bodily edema. This frequently occurs towards the woman. Meanwhile, symptoms that may occur during pregnancy, including mild anemia. Following birth, the following symptom may occur: severe hyperbilirubinemia and jaundice, as I said earlier, which is more, these signs and symptoms may occur on the woman or the pregnant woman or the baby itself. General and advanced laboratory diagnosis. All pregnant women should be screened for RBC alloantibodies at their first prenatal visit during the using the indirect antibody test. After a woman is found to have RBC antibodies, multiple procedures are used to estimate her risk of developing clinically severe HDN. Serological testing cannot detect zygosity in the case of anti-desensitization, and molecular testing for the rhesus D gene copy number is required. Lastly, tests that can be used, or advanced laboratory tests, including the identifying rhesus D negative mothers who carrying rhesus D negative fetuses and thus do not require RAADP. Figure 4 shows the direct COM test for fetal RBC coated with antibodies. Now, common and advanced treatment. The common treatment, usually it is very critical to treat HDN antenatally in severe fetal anemia to avoid hydrops fetalis or fetal mortality. Now, the advanced treatment include exchange transfusion, which is get the advantage of removing both bilirubin and maternal antibodies from circulation, and it will help in correcting anemia. New research on the disease rhesus immunoglobulin and alternative rhesus D specific therapy have been in widespread use in a number of countries for more than half a century, and are one of the most effective immunomodulatory medications currently available. Despite its effectiveness, the mechanism of action is yet unknown, and it's currently being studied. On the other hand, antigen modulation, also known as antigen loss or antigen suppression, has been observed in the presence of antibodies on both RBCs and WBCs in people and animal models. At the moment, it is unknown whether RSSD antigen modulation happens in the presence of rhesus immunoglobulin, and if so, whether it contributes to rhesus immunoglobulin immunoprophylactic actions. So both of these mechanism or both of these management are now being studied. In conclusion, within the lifespan of the majority of pediatricians, the spectrum of hemolytic disease of the newborn has shifted beyond recognition. HDN was practically synonymous with rhesus D alloimmunization 30 years ago, was a prevalent newborn issue. It was typically unaffected by antenatal medication and resulted in overt fetal or neonatal hemolysis, resulting in significant newborn hyperbilirubinemia and associated anemia. At birth, affected infants were frequently ill and unstable, required repeated exchange transfusion, and experienced significant neonatal morbidity and mortality. However, the introduction of routine postnatal prophylactic anti-D immunoglobulin for rhesus D negative women, as done in United Kingdom in 1970s, significantly reduced this kind of HDN, and so ranks as one of the great success stories of modern prenatal care. While the clinical load placed by HDN on neonatal services has been significantly decreased, it has not been eliminated totally. Newborn pediatricians continue to recognize a variety of distinct manifestations of neonatal hemolysis, the majority of which are much more modest than the conventional neonatal emergency presentation with severe rhesus D illness. And that concludes my presentations for this topic. I thank to Dr. Mahadev for this opportunity, and I thank to all the audience who are watching this video. Thank you very much and have a nice day.